Okay, everyone, I show it as 3:02 on June 14th, so I'd like to call to order the special session of the Seneca Healthcare District Board. That said, I'm going to call a roll, and I want to just say this before we start. I am coming off the tail end of a cold, and I feel fine, but I'm coughing still. So if I lose my voice or start coughing, please excuse that. All right. So let me take attendance here from the board members. Dr. Walls?
Here.
Okay. Jerry Nielsen?
Here.
Okay, and Kristen, are you with us?
Here.
Okay. Rich Rydell? Does anyone have any information about Rich? No? Okay. And well, I am here, Ken Crandall, so we do have a quorum. All right. Please join me in the Pledge of Allegiance to start the meeting. I pledge allegiance to the flag, the United States of America, and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. Excuse me. That brings us to the public comment section of our agenda. So folks who are either in the boardroom, I don't know if we have any members of the public in the boardroom or not, or who have called in, now's the time if you'd like to address the board, make public comment.
Ken, I don't have anybody with their hand raised here. Renee, do you have anybody that we were joining? Okay.
Okay. That said, we can move right into our action items for the day. The budget for fiscal year 2021, 2022. And I guess that would take us to Steve. I wanted to make one comment before we move forward with this. I'm reflecting back on a telephone conversation I had with Noelle Cogman, and she was advising us against taking action on significant matters and special meetings as opposed to our regular scheduled meetings. We can share information and have discussions, but she kind of advised against them. Reflecting back to when Sean was first hired. She told us not to do that in a special meeting. It had to be done in a regularly scheduled meeting. So I am gleaning from that may not be appropriate, according to Brown Act, to approve a budget today, although we can, I think, discuss it in some depth. Anyone have any thoughts that are different than that?
Any objection to us approving the budget at our next regular meeting?
No, I think that we had discussed that. We just put out, or I asked Renee to put out there just in case you guys were overwhelmed with my work and ready to approve it. But the plan was to talk about it and then bring it back to the final meeting, or the regular meeting and then. That's
prudent. I gotta tell you, I'm having a little difficulty on my end hearing you, a little muffled and garbled through it. Okay. All right, I'm assuming Steve is in the room.
Yep.
Okay.
I did not hear, can you hear me now, Ken?
I can.
Okay, perfect. I did not hear the roll call. Is Kristen here? Is she here?
Yes, I'm here.
Okay, hi, Kristen. Sorry, I didn't hear your name. Want to know who I'm talking to, board-wise. Okay, so the first document what we're gonna start with is the document called Presentation to SHD Board 06-14-21. And this is just as it's described, it's my presentation regarding the budget. there's, in addition to the budget itself, there's some other information that we will go through. Some of it quickly, maybe some of it we'll talk about. So I know this information went out last Friday. Does anyone have any comments or questions before I start? Okay.
Definitely a lot of work was put into this. It's very much appreciated.
Gary, I have to say, it's a little difficult, having a little difficulty hearing different people, so.
Okay.
just put
Steve,
that out there.
I'm sorry, can I just thank Steve and the rest of the team for putting together such a thorough analysis and budget for the board.
Okay.
Thank you.
All right, so what I did on the presentation, this is a PowerPoint presentation, and what I did for this document is I printed it out, and then I went two slides per page. So we're on page 1 right now, going from the title page to the first slide, which is the second slide on page 1. And I just wanted to present our historical gross patient revenue. And it's kind of interesting, if we go back to fiscal year ended 2016, you can see that 16, 17, 18, and even 19 were all pretty similar. They're similar in dollars. There's different things going on during that period of time as far as the revenue and what generates the revenue for the hospital. But the big thing we see here is that in 2020, we saw a big drop from the mid to upper mid $20 million per year to $22,500,000 for 2020. Everyone just immediately says COVID. So yes, COVID was a factor in that, but what even happened before we started seeing the impact of COVID in the spring of 2020, March and April, is that we had lost Dr. Salehi, and that we had brought Dr. Cooper on. So we lose one physician, and then we bring on a new physician. And so this will be kind of a recurring theme item for discussion as far as what's the key for Seneca, as far as returning to those historical revenue numbers and then turning around, if you will, our financial performance. The fiscal year ending, the current year we're in, ending June 30, 2021, for budget purposes, we used February's information, year-to-date information, so 8 months of the fiscal year. And at that time, we had projected that the current fiscal year will end at just over $21 million. So somewhat similar to 2020. Also provided some information here where I've used the numbers through April to project out, but for the creation of the budget, we used February. So if we go to our second page, third slide, this is a look at net patient revenue. And this is also another dynamic. I know I talk about the healthcare finance voodoo and how our reimbursement works, not only just being a healthcare provider and the unique things regarding reimbursement, but the fact that we're a critical access hospital and that we also operate a certified rural health clinic. Our reimbursement for Medicare can be quite variable. So again, fiscal year 16 through 19, pretty consistent. We were mid to high mid 20 million, and our net reimbursement, our net patient revenue came in at 13, 14 million. On a percentage basis, it was right around 50% or so. And then in 2020, we saw the first impact of of the drop in our revenue, both from what we talked about as far as the provider transition and turnover, and also COVID, but our net reimbursement as a whole from the facility-wide jumped up to over 60%. And then, as you'll see when we go into the budget in more detail, it's going to be even for the budget year, it's going to be even higher. It's going to be in the mid-60s. Talk about this a little bit when we get into the detail of the budget. It makes it very challenging to play with volumes and utilization because the revenue, it has such a dynamic impact. You know, you move one thing, another thing moves, kind of ideal. But the point here is that up through 19, our net reimbursement was pretty consistent as a percent, and then 20 it jumped, and then 21 again it is increased, likewise increased. Operating expenses, and I think the takeaway here is that, and we talked about this, those of you guys that were here when we presented the 19-20 budget, is that, remember looking back at the last couple of slides there about revenue and net revenue, it's been very flat for the period of 16 through 19. As you see, our operating expenses have increased at least from 17, 18, and 19. So therefore, our revenue's been flat and our expenses have been increasing. And, you know, that's led to let's see, I'll get into the net operating loss figure, but it's led to an erosion of our financial operations. Salaries and wages, same discussion here. Moving on to the next slide, slide 5, page 3, or top of page 3.
Can I just ask a question?
Absolutely.
So on salaries and wages, what's the delta in our FTE numbers from year to year? So do you have a rough idea if we're moving up in FTE numbers, or is this just all contractual stuff?
Yeah, we went back, Karen actually, Turner brought this up. We went back to 16 and 17. We were running around 90 FTEs. And then in 18, we jumped like 10 FTEs. And then it's just been an FTE here or there, if you will. We're now projected for 21, we went to 103, and then budgeted, we have 104. And when we talk about FTEs, it's taking the total hours, the total paid hours divided by 2,080. So we have more than 103 employees. We have approximately 120 bodies here. But paid hours were 103, 104. And then to Sean's question, going back to where the revenue was, the salaries were $5 million. We had approximately 90 FTEs. Now, yep, absolutely.
Around that time was also when we were encouraging the hiring of FTEs versus contract labor too. So that would be partially offset, right? Our contract labor expense.
Yeah, we've seen some change in that. The problem is with this historical pro fees. Next slide, slide number 6. It doesn't show that direct relationship, but we did look at it, and the contract labor has gone down over that same period of time, and it's mainly in the area of nursing. That's our biggest contract labor area. So a shift from contracted nursing to employed nursing. So moving on to page 4, top is slide 7. Other expenses, fairly benign here. There's some ups and downs. Nothing here that is really significant enough to specifically discuss. So if we go to the second slide on page 4, it's slide 8. This is our operating loss and income, and this is where Sean and I have our heartburn. You know, if we go back to 2016, top of the slide, we were almost operationally profitable, which is really commendable for a critical access hospital. That I know a lot of critical access hospitals report profitability, but one this size, a true frontier critical access hospital like Seneca, to be even close to operationally profitable is incredibly commendable. But then we see what's happened over the next, 4 years specifically, that we went from almost break even at $102,000 loss to $875 to $1.9 million to $2.5 to $2.9 million losses. And this again is just a direct relationship of the stagnation or the flat lining of our revenue and the growth of our expenses. And then of course, 2021 projected was really all about COVID.
Have we received any, I know we're not gonna get there, but the PPP stuff, monies?
Right.
I guess we haven't realized any of that, right? And can we use that, we're supposed to use that for our salaries, right?
Correct. So in 2021, we did recognize some revenue related to the provider relief funds, about $700,000. But it is not completely reflective of the impact that we've experienced during that period of time. We're still sitting on $3.5 million in provider relief funds that are unrecognized and the triple P loan of $1.5 million.
Yeah, we can't recognize that for our salaries that we paid over this last year.
And as soon as we make a determination of exactly how we're going to account for those funds and how we're going to be able to apply it to our actual expenses. So when we look at the expenses we incurred during COVID, the biggest expense that we incurred was keeping everyone employed. We also continue to receive all of the increases that are in the union MOU and negotiated increase. We gave everyone the one-time payment last fall, totaling about $100,000. And so all of that was our expense of operating during COVID, related to having the triple P loan, because with the triple P loan, we said we wouldn't cut anyone's pay, we wouldn't reduce positions. So now it's a question of how much are they going to allow us to claim against the loan if they make us claim it against the loan. There's still a question that whether or not that'll be treated the same as the provider relief funds, where we say, okay, HHS, the government says, okay, here's all the money we gave you, show us what you spent on COVID, and then offset that against the money you received, and then you recognize it as income. Well, if we wouldn't have made the commitment to do the triple P loan to get the forgiveness, which says we're going to do all those things, we could have laid people off. We could have withheld wages, saying we don't have the money. We could have said when people had to go home because we lost daycare and the schools closed, and we continue to pay everyone. So it's a question of how are we going to be able to say those are the expenses we incurred because we took a triple P loan, and how much can we offset? So I don't. The short answer is we're still unclear as to how they're going to actually consider that.
So if they provide guidance after we've ended this fiscal year, do we go back and update this fiscal year, or are we going to somehow show that on our next fiscal?
Yeah. So the one thing that
That's what I'm really asking, is because we're almost at the end of this fiscal year.
Yeah, we are.
Receive the money in.
Well, so the one thing that did happen is last Friday, Health and Human Services at least released guidance on the reporting requirements and reporting deadline. What they said is that if you received funds before June of 2020, so last year, and we received the bulk of our money in May. So we received it for June in 2020. They're saying that you have until June 30, 2021 to spend it. And that we have to report our spending and our reconciliation, if you will, of the money they gave us by September 30, 2021. Which is within enough time for us to know, as part of the audit, even though it's after our fiscal year end, the auditor's not, that's typically when they come in and they do their thing. But what's still not clear is that, yeah, they've given this little, white paper on what we're supposed to do, but now people like myself and others are gonna start asking questions, hey, what about this, or how are you doing this, and how are you gonna consider this? And so we still have some arm wrestling to do over all of that
We have till the end of September to submit.
to report.
Okay. That was my concern. Thank you.
Yeah, and so one other component of all this is the lost revenue. Is they're gonna give us consideration for the impact to our revenue. And so we'll have to determine that, and that's, again, an interesting dynamic because what about the additional reimbursement we get from Medicare for having our revenue go down, and so our reimbursement percentage from Medicare going up? So a lot of things are unclear. I think certainly we're probably going to bring in a chunk of that, $1 million, $2 million, $3 million, something like that, of the two together. So
Certainly unprecedented times initially.
That's crazy.
the good news is that we've got $5 million in the bank with the government's money that we haven't touched, if you will. We survived off of our other funds, our other reserves, and so that money's sitting there. So if we had to get the whole thing back, it's just sitting there and write a check with no difference. So we're not like these other places that have been horribly impacted, and the money they receive is not going to be enough. They've actually experienced a loss beyond the money they've received. So that's the good news. Okay, so the operating loss, big thing for us, big thing of getting it back to, the next slide, top of page 5, getting us back to a percentage, target percentage. It's 2016, we were right under 1%, we're at 0.66, great. 17, it jumped to just under 10, 18, just over 13, on and on. 19 was 17, and then 20 was just under negative 20% margin. So negative 20% margin in any other business than ours you'd be out of business. But we receive, this is without the supplemental payments and taxes and things like that. So there are other sources of revenue and cash flow that offset this loss currently. But as you can see, for 2021, we're projecting a 37% loss. That's can't have that.
So our goal is 0.
Our goal is 0.
Yes, it is.
Sean's goal is 0.
Charles' goal is net zero. Operating.
Steve's goal is something around 10, a loss of 10.
To start.
Yeah. So that's where we're at. Just to give you an idea here, this next slide, top of or bottom of page 5, this is the non-operating revenue outside of the supplemental money. So this is really taxes, donations. Our taxes we get about $600,000 a year from Lewis County. You can see in 2021 it's $1.5 million because we did bring in about $700,000 from the provider relief funds so far. So go to the top of page 6. This is our supplemental payments. This is the gross amount, in supplemental payments. The main things are, the Prime Grant, which is transitioning to a new program, hospital quality assurance fee program. There's a couple other things, AB 113 program that gives us supplemental payments. You can see we started off in 2016 at $1.2 million, and it's just progressively gotten higher. Some of those 18 and 19 were catch-up years, so we received more than one full year. 2020 was indicative of about 1 year. And then 2021, same idea. In order to get, bottom of page 6, in order to get, oops, that's historic, sorry. So with those supplemental payments, then this is our historical net income loss. You can see we've been very healthy because of the supplemental payments starting in 2016 at 1.9 million to those big years at 18 and 19. And then the last 2 years, 2020, 2021, a little less in the supplemental payments and a little more in the operating loss. But we've still been profitable. But in order to get going to the bottom or the top of page 7, in order to get those supplemental payments, we have to make what's called an intergovernmental transfer. You can just see the amounts there. One of the nice things was, is if you look at 2020, when the Affordable Care Act was done, Obama administration expanded Medicaid. California chose to expand Medicaid. Typically, they have what's called a federal matching, and it's like for each dollar that Medicare spends, federal government puts up 60 cents on the dollar to match. On the expansion population in 2020, we received matching at 90%. So it's almost pay a dollar, get $2 kind of thing. But in 2020, the relationship was more pay a dollar, get $3 kind of thing. So
on this, are these numbers net that we've made, or does that include payment that we make to get the reimbursement?
yeah, so if we go to the top of page 6, slide 11, that's what we received. So in 2016, we received $1,240,000. But if we go down to the IGT slide on the top of the next page, we had to give them $595,000 to get that. So the net is $600,000, $650,000.
So Steve, help me with the slide on the bottom of 6 versus the slide on the bottom of 7.
Yeah, so just from an accounting standpoint, the intergovernmental transfer isn't designed to come from the entity that receives the supplemental payment. It's designed to come from a public entity. So in the case of Seneca, the hospital district, the healthcare district makes the intergovernmental payment, and then the hospital receives the benefits. So what they do is they have us show the supplemental payment that we receive in the income statement as revenue. And then they show the intergovernmental transfer as a reduction of our equity. So it doesn't literally go through the income statement, but obviously it goes through our cash flow. And so I try and present it like I try and present it so that here's our budget. Yeah, we could say, here's our net income. If we look at the bottom of page 6, sure, here's our net income, and it looks all fine and dandy. But in order to achieve that net income, top of page 7, slide 13, we have to pay that out. So when we're budgeting, we had better include that intergovernmental transfer in our budget, because this is a resource requirement that we have here. And so if we create a budget without consideration for the intergovernmental transfer, we would have this, each year we'd have this resource reflected here on slide 13 that would be in essence unbudgeted. So we have to budget for the outflow, just kind of like maybe the best way to think of it is, you know, paying your mortgage. If you just said, well, I'm gonna budget for only the interest portion of my mortgage versus the principal payment kind of thing. So you still have to pay both pieces of it.
So the one on the bottom of 7 reflects the outflow and the inflow.
Yeah.
whereas The one on 6 only reflects the inflow.
Correct.
Okay, thank you.
And I'd like to almost call this, I was at one time calling this like a cash flow income. But in order to be a true cash flow income statement, you gotta add back depreciation and back out any principal portion of long-term debt. But since they make us the accounting standards, make us show the supplemental payment that we receive as income, I think it's important. And this is kind of like going back to Dana Sandell, if you will, trying to, you know, ferret this out. You know, what is the net number here? What are we really getting? What is it costing us, kind of thing?
We have to know how much we have available.
Yeah.
So,
Say we balance our budget with supplemental payments, but then we don't have the IGT budgeted in, then we're looking at, you know, coming up with another $1 million, $2 million. That goes straight off the bottom line, right out of the bank account. So you can see that again here, the Seneca's net income, slide 14, bottom of page 7, Seneca's net income with the IGT is $1,200,000, $1,300,000, $1,200,000, $2.4, $3 million, just under $1 million, and then $344,000 projected for 2021. So supplemental payment programs have saved rural hospitals such as Seneca, saved everybody, saved Eastern Plumas, saved Quincy, saved Plumas District, saved Mayors, Modoc, everybody. This was a game changer for all of us. But unfortunately, we're gonna get a little glimpse into life without supplemental payments when we go into the budget. Okay, so page 8, we get into the COVID discussion. This is just a narrative here. We kind of talked about it a little bit at the beginning, that reductions in net patient revenue and all expenses directly related to COVID during the pandemic emergency period will be recouped through the receipt of these provider relief funds. I state here, at this time, it's still unclear how this will be specifically applied and for what period. We do have an idea now about the period that they've now said that anything we received before last June, we have until end of this month to spend and have to report by September. And then anything we received after June, which we did receive a little bit of money, and there are some opportunities out there to go get more money. We were hesitant because we didn't think that we had spent the money we already had, that we could maybe go out and do that. We would have till the end of the year to spend that. So we'd be looking at that. Just rough estimates at this time, March of 2020 through June of 2020, this is net revenue. Compared to the same time of 2019, we've lost 1.1, we've seen the impact of $1.1 million. Lost revenue for July 1, 2020 through April 2021, again, the same period of 2019, we've lost $1,025,000. So $2.1 million potentially that we'll be looking to apply provider relief funds to. Also, let's see, since the beginning of March 2020, all the way through April, we spent in excess of $500,000. That's just a rough number at this point, in directly related COVID expenditures. So again, rough numbers right now, we think we're sitting on possibly $2.5 million that we would claim. The wild card in all this is on this slide here, there's no consideration for any of the salaries, expenses that we've incurred, the increases we've given, the one-time bonus we gave, people we kept employed, how we'll be able to claim that, and whether or not we will have to do this same matching of provider relief funds in the form of a PPP loan against direct COVID expenses for labor-related expenses. So,
Steve, Ken, just a quick question. Are there other districts that are in a very similar situation that you're aware of?
a couple of them, yes.
I'd be curious what that, I mean, how much pressure you can exert collectively.
I think there's going to be a lot of pressure on the PPP loan because, you know, fair is fair, right? But, you know, everybody went into that PPP loan with good faith. And we said we were going to do this, and it was a perfect program for someone like us. We were for a healthcare entity to keep everyone employed, keep everyone safe. There when the community needed us, we were there. And so it was a perfect program. And for now to penalize us after the fact, and then how you quantify that we could have let people go, we could have not paid people, but there would have been severe consequences to that. But our ability to do that was taken away by the commitment we made. So I'm sure there will be a lot of discussion about that.
Yeah. Okay, thanks.
Okay, so going to the top of page 9, this is a summary of the provider relief funding that we've received so far. Through the federal government, just COVID related, we've received $4,216,095. Just over $4 million of it was from the CARES Act funding. There was a couple things to the CARES Act, couple phases. The big one is that they this is funny. They just I don't know that they knew what to do, so they just gave every critical access hospital $3 million in May 2020, which was great. Really provided a sense of peace to us to know that we had that money there if things really got critical up here, that we were going to be able to get through it. There's been some other smaller funding that's come through after that initial CARES Act money. You see just under $180,000. And we're projecting that as of June 30, 2021, basically as of April, we've recognized $704,000. So right now we have an unrecognized amount or a deferred revenue of $3.5 million.
And what can we apply the CARES Act funding to?
Anything related to COVID, I mean, supplies, equipment,
Testing.
Oh, good. How could I forget that? All of the testing expenses, which is huge. All of that stuff we sent out to LabCorp, buying the respiratory panel machine and the materials for that, absolutely. Paying, we had to pay a premium on registry people. So,
Does that one also, here's your report for September?
we will report through June 30, from the beginning of time through June 30, 2000, the end of this month in September. And that'll be everything. The rent on our building outside the ER, I mean, everything. And that was a great thing to get. That was
Generators.
the generators, on and on and on. But yeah, the testing was huge because some of the money was specifically designated. Some of the rural health clinic monies that they gave out were specifically designated. And I think our ability to do that surveillance testing, because that surveillance testing was on our mind. There's no one we can go for that. And it was mandated by CDPH that we had to do that. And then again, last, we also have the Paycheck Protection Program loan. And I will be doing the forgiveness application in the next month or so. And we've already done a first pass at it. We think that there's two elements to it. First is that you calculate how much of the loan will be forgiven based, again, upon keeping people employed and keeping their pay the same. We've not had any, there's not been any, I don't know the right way to say this. We haven't let anyone go for cost saving measures. Anyone that's been let go involuntarily during COVID was related to personnel matters, which you get consideration for from on the PPP loan. And obviously we've kept paying everyone, continued the increases and everything. So when we ran it, we think that we'll get 100% forgiveness. So that was the top of page 9. Okay, wow. All that, what a preamble. Okay, so here's our operating budget for fiscal year 2021, 2022. I guess just simply stated, it's incredibly difficult, if not impossible, to project where the next year is going to take us. We could have the best plan, the best laid plans of mice and men, whatever expression is, that we could have a great plan, but we thought we had a great plan going in March of 2020, February of 2020. And then all of a sudden everything gets turned upside down. So we don't know, one, if COVID is going to come back in with any anything near the level it was before, the disruption it did on us, the horrific impact it had on people, that type of thing. The other thing we don't know is that, are people going to come back for healthcare? How are they going to seek their healthcare in a post-COVID environment? I guess we're somewhat fortunate up here that we don't have to worry about the impacts, the economic impacts where people have lost their jobs and then it affects their insurance. I don't think we've really seen that. The biggest employers in our area are us and the government. And the government's still chugging along, the schools are still there, the county's still there, Forest Service is still there, Olive Pine is still there. So we don't have that variable where we have to wonder, are we going to all of a sudden see a spike in our uninsured population? Are we going to see a spike in our Medi-Cal that pays us less than commercial insurance rates? So incredibly difficult to with any level of confidence project out something. So we pun it. We just say, we're just gonna say, not much is gonna change. And so when we did this, that's kind of what this budget reflects here, is that we didn't project a lot of change for 2021, 2022. And this first slide on page 10, slide 19, is a summary of our budget. So see net patient revenue, other operating revenue, and then salaries and wages, other operating expense. We get down to an operating loss of $2.9 million, which is a big improvement on fiscal 21, and we'll talk about that. It gets us back more to where we were 2020, 2019. But there's a lot of moving parts on this. Then we get down to the non-operating revenue, which is, again, the taxes and the other stuff. But then the big thing is the supplemental payments. Our net supplemental payments are down substantially for fiscal 21, 22, and we'll talk about that as well. So, you know, it takes guts to walk in this meeting and show a budget with a loss, bottom line loss on it, but we'll talk about that. There's pretty much, there's no way around that without making some big assumptions about things. So let's just kind of dive into the numbers a little bit. So on the bottom of page 10, slide 20, so with what I just presented on the previous slide, as I mentioned, the operating loss does represent a decrease. So a decrease in loss is a good thing, of almost $2 million. And the first bullet here says that this $2 million improvement in our operating loss is highly or mainly due to that we are projecting a $2.157 million increase in net patient revenue. And this is made up of a combination of a $1.4 million increase in gross revenue and a almost $735,000 decrease in contractual adjustments. And so before Jerry asked me, that doesn't sound, shouldn't they go the same way? Is that, yes, they should, but we'll show that why the decrease in the contractual adjustments is coming with an increase in gross revenue. Then there's some smaller things, the operating revenue, just a small change. 270,000 increase in salary and wages. We'll go into the detail of that. Again, we're always starting with, we're not going to give with our operating loss and with our operating loss, I don't need to say anymore. Our starting position in any labor negotiations is that we're not going to propose any increases above the step increases we're already giving, which the union and I have a very, very strong disagreement on about that step increase that we give to our employees, which is 4% for most of them, is not a financial increase to them. That's a financial increase to them, and it's a huge financial commitment on our part. So
Do we still have to make some adjustments to raise the minimum wage? Or are we?
yeah, we got one more year. I think we're at 14 now, and we'll go to 15 next year. So, but we've really moved everybody. So hopefully it won't be as significant next year. But we did move a lot of people with this last go around. So, and we put in, for budget purposes, we were able to load in everyone's new rate from the compaction, as Jim calls it. So those numbers are good, and that's what the steps will come from. There's a decrease in professional fees, both medical and other, and we'll talk about that. Small increase in contract labor, and then small increase in other operating expenses. Okay, so here's the voodoo. So net patient revenue, top of page 11, slide 21. I mentioned we're gonna have a $2,157,000 increase. net patient revenue over 2021. 1.4 of that is going to come from an increase in gross revenue. We are not projecting any increases in utilization at this time with the hospital, other than two areas. That during COVID, we did not, one of the key things we did during COVID is we did not accept post-COVID subacute discharges into the hospital. We took our nursing home and we said, those guys are untouchable. Those guys, we're going to do everything in our power to protect them. And so we did not do any new admissions. We lost a few residents during the time, and our census went from being almost full, 16 beds, down to 9 or 10 residents at its lowest. It started to creep back up. We started to get some admissions, and we're now at 14, and we're looking to do our placement for resident number 15 right now. So we budgeted for 15 residents. We highly confident that we've historically run at that. We're almost always full. We have a waiting list. It's a great nursing home, great people, great everything, great doctors, great. It's a nice place. So we're highly confident that 15 is achievable, 16 is just unrealistic because you're just going to have open beds from time to time. So that was one change. The other one's the clinics. The clinic took a big hit in 2011, back in April, when we started restricting access to the offices, and people had fears of even coming into the hospital. So we took a big hit. We're going to move from 8,300 visits to 10,200 visits, and there's some analysis in detail in there. One area we did decrease is lab revenue because we anticipate and hope that the amount of COVID-related testing will decrease during the budget year. Next bullet, we're not anticipating any specific rate increases to areas other than we will bump the nursing home rate as Medi-Cal changes our rate, and then no changes in utilization except as for long-term care in the clinic. So obviously, if our clinic visits go from 8,300 to 10,200, our outpatient revenue is going to go up as tests are ordered and referred. It's just very, very difficult to then say, okay, so how much is that going to be? And then how is that going to change our Medicare reimbursement? So we just left that alone. And I think that that's what provides us a little bit of a cushion, if you will, that we know that if we do hit our clinic visit targets, which I don't see any reason we can't, will show that's still below historical numbers, that will generate that additional outpatient diagnostic revenue. Okay, lastly, last bullet at the bottom, a $735,000 decrease in contractual adjustments due to a change in patient mix. So the two areas that we're proposing the increases are long-term care and clinic, and both of those areas are reimbursed well above our overall average, even though we've gone up into the mid 60% net patient revenue percent. Long-term care and clinic are reimbursed at almost 90% of their charges. So that's going to bring that adjustment percentage down. And what it ended up doing was our adjustment percentage is projected to be 34% or 66% net patient revenue for the budget versus just under 40% adjustment and 60% net reimbursement for 2021. So does anyone want to talk through that, or that makes sense in a weird way? Okay. Okay, so here's this next slide, bottom of page 11, slide 22. I think I did this right. I went back into historical here, I went back to 2015 and did 2015, 2016, 17, 18, 19, and looked at our clinic visits. And if we go back to 2015, you can see that we had almost 14,000 visits in the clinic. You know, Dr. Walls and Dr. Ware we're seeing good amount of patients. We still had Dr. Ward here. We started to have the transition in that one office. Oops, sorry. Dr. Nielsen, we went to a locum, and then ultimately went to Salehi, and then finally Cooper. We had more specialists here. The walk-in back then, some of you guys, I'm sure Dr. Walls will remember, I asked Kelly Pettigrew about this, was Tanya McDonald. And what I was told is that Tanya did the walk-in, but she did half walk-in, half scheduled, which is kind of a cool thing if you can do that. So she was basically running a clinic herself. Then we went into 16, and like I said, we went for the transition in the two physician offices. Dr. Suarez came in, and Dr. Slade came in. And then in 2017, we went to a straight walk-in. I don't know if that was Linda Bono. She was here when I did my physical in March of 2018. And then you can see that the one physician office, the visits stayed up, but the other physician office, Dr. Ward's office, and I don't know if it's fair to look at it that way, it's whatever, it's still a physician office, that had dropped off substantially. The walk-in goes back and forth, but another big thing is that in 2018, our specialty visits dropped off, and then it's gone down to now where it is 2019. And now we started, beginning in 2017, we went under 12, and then we were right about 11, and right about 11 for 19. Next slide, top of page 12. This is the clinic visits for 2020 through 2022 budgeted. So 2020 actual, 2021 estimated, and then the budget. And you can see that the one physician office, Dr. Cooper's office, has stayed below 2,000 visits. The Nielsen there in that one line is Teresa Nielsen, nurse practitioner, and then Sonia Troxel coming in, physician assistant, here at the end of 2021. Walk-in numbers have gone down to more of just a true walk-in, no scheduled, and then the specialties are right around 1,000 visits. 2021, of course, we get hit with the COVID impact, and that the Nielsen Troxel office was open for some time. So what we've looked at for 2022 is Dr. Ware's going to kind of do her thing for a couple more years. She's going to hit 2,000 patients. Dr. Walls, we hope we get you on your boat here soon, and but we think that office, whether it's you or a transition to another provider in there, easily can do 1,500 patients. Where we really need to get our clinic visits up is in that other physician office and Dr. Cooper's office. 2,600 is about, it's less than 2 patients per patient care hour. So very achievable. And then Sonia is going to be 3+ days. So 1,800 is achievable. The walk-in is what it is, and the specialty kind of is what it is. So there's really not a lot of dramatic, hoping and wishing. It's getting the one physician office to seeing 14 patients a day. Dr. Ware and Dr. Walls doing their thing, or however that works out. Sonia doing her thing, and
Well, I think that there's one thing one one calculation that's not in here, and that is the electronic health record. If we really do get a better electronic health record, I think you'll see all these numbers go up. Because I just don't think that outside the offices, people appreciate how much it slows everybody down. It really is a slow system.
Kevin, we do, we understand the hindrance, how it hinders our workflow, and Steve and I have spoken that about a soft cost related to the EHR. You know, we're not gonna put any kind of perform or ROI to that, but we realize that it hinders your ability to see patient after patient, because it's
Yeah,
a bit of an
it's
albatross.
a slow system, yeah. And it will improve these numbers if we get a better system.
Yeah, and I think these are, the budgeted numbers again are not aggressive, these are CPSI achievable.
Yeah.
Well, the other piece to this too is, we need to be bringing patients in to see these physicians, these providers too. Right, how are we gonna get more people in the door? That's what. Right?
To some extent, I think so. I think that, you know, maybe it's a leap of faith or something like that. And Sean, I'm just talking from raw numbers. I'm not talking from a marketing public relations standpoint. I'm just saying that, you know, we look at our numbers, we look at the Whitley study. You know, there's 13,000 visits in our market area. So they're there.
This
It's-
looks reasonable,
It's us being there for them. It's our information system supporting the physicians, being able to see them in an effective manner, efficient-ish manner. But it's us being there for them.
It's a combination of reputation, it's a combination of availability, it's a combination of awareness. The electronic health records one. It's, you know, the only way, you know, as we zero this budget and apply it from an expense perspective, and there's room there still. We just want to get draconian around expenses this time around. The only way is up. We have got to increase our volumes. That's just the only, and we have a ton of capacity to do that. You know, with keeping our expenses the way they are, keeping our staff as it is today, we can literally absorb at least 60% more. 60% more visits currently, albeit the EHR is a bit of a hindrance, but we can absorb 60% with our current staffing matrix right now.
So Sean, it's Ken, just a comment, question, sort of. For me, when I hear this discussion, I can't help but wonder what the patient experience is, and are we user friendly for people in the community? I just want to make sure that's something that's under consideration as well.
I'm sorry, did I miss that? Was that around our technology?
Patient experience.
Oh, patient experience is everything. I can tell you that, you know, Project Welcome Mat, the whole concept around Project Welcome Mat is not just for treating ourselves internally, professionally, it is the entire patient experience into the community. What is it like to come and do business with us? I mean, the medicine is important. You've got to have good medicine, but once again, the experience is what really generates the buzz. So yes, Ken, to answer your question in the short term, it is about how we treat our patients. It's about the experience when they get here. And that is 100% focus. That's 100%
How accessible is it for them? You know, are hours friendly for consumers? These are just questions. I don't know the answers to them, but just things I think everything's open to consideration at this point.
Okay, the concept of consumerism is one that is constantly on the tip of my tongue. Consumerism, how do, you know, healthcare, the consumers are now driving business. Okay, it's everything from their interaction with our portal to their interaction with our admissions people to how their medicine was to a follow-up. What was the follow-up like? Did they, you know, were they questioning? We're doing those things. We have constant improvement to get there, but yes.
Can patients schedule their appointment through the portal? Because that would make it easier for them, and is that something that we might consider doing?
Absolutely. I think it's really important to be able to schedule an appointment with your physician on our portal. but the current portal we have has no capability in that regard. But the Cerner portal does. For those things that can be scheduled, that is a great tool. Yes,
Because so many people are moving more and more to wanting to do that rather than pick up the phone and make a call, make an
Absolutely.
appointment, so.
absolutely. It's the consumerism part of healthcare, letting them drive the care.
And I have a question also. This is Kristen. What, do we see any change in the access of just patients walking in, say to the clinic without having to push the buzzer on the door? I know that's all with COVID, but when is that expected to change their easy access into the facility?
Listen, I wish I had a crystal ball. I do. I wish I could tell you exactly when that date's going to end. You know, we are really following the guidelines of the CDC. We're going to be following the guidelines based upon the June 15th release. And our infectious disease nurse, you know, we must remind ourselves that we are not out of COVID, although it's backed off. You know, our higher calling is to protect every patient that's in here and our staff so that we can continue to provide care. I don't know the answer to that. I think it is a pain. I don't like the fact that people have to buzz the door, can't just walk in, but I do not have a good sense for when that's going to end.
Would it be better if patients call for someone to come in? Would that be more patient friendly than buzzer?
I have to say, I have not had complaints from patients about buzzer.
Oh, yeah.
No,
And most of them bring a cell phone, and if the weather is not good, they call and say, I'm out in my car, and someone comes out and opens the door.
we have more of a challenge in the hospital emergency room when they come in that door because the staff are usually busy. It's not so much in the clinic. But if the staff are busy, the staff to answer that buzzer quickly. You know, and that's, we've gone through several iterations about who does that and such so that they don't stand outside waiting. But I don't think screening is going to stop anytime soon. So if it stops ever, I hope it does. Okay. Steve.
Okay, so those are the assumptions and those are the mechanisms of us achieving the increase in clinic visits. If we move to the next slide on the bottom of page 12, slide 24, a little discussion about the labor costs. So we do have an increase in salaries, and we did have a decrease in benefits. Again, that is counterintuitive, and it really is when we put it together. The people that, you know, we look at who's going to have health insurance. Some people are opting out. Some of our employees, we have fantastic health insurance, but some people still turn down our health insurance for whatever reason might be. The other thing is that we are getting a subsidy on our unemployment. I don't know how long that's going to last. The state's paying half of it, whatever it is. I mean, even if we have someone leave and go to work somewhere else, depending on their time there with the next employer, if they go to take another job and they leave that job, the unemployment comes back to us. So, and we just do a pure calculation of the benefits, and that's just the way it came out. The overall percentage is a little lower than historical, so we'll keep an eye on that. Again, I mentioned that there's from where we set the budget, we're only anticipating doing the step increases for the employees. We budgeted an overall 2.5% wage increase on wages during the year. The average hourly wage for the budget is $36.17 versus $35.17 for the estimate, and $34.35 for 2020. You know, there's a few other than just the natural increases, and we did have a rather large bump when we did the compaction on some people, some of our employees, and rightfully so, I guess. received increases of upwards of 10%. So I'm a Republican, but I do believe that there should be no such thing as the working poor. Everyone deserves a fair wage, and I'm supportive of that. That's a positive thing that Seneca always does. I think we pay a very fair wage, and we treat our employees very well when it comes to those, their compensation and their benefits. So we've continued that with our latest go round. FTEs, just a slight increase, and then a little bit of an increase over 2020, nothing significant. There's just some gyrations. Now, one thing we did do, we have made, spent a great deal of time with Karen Turner doing the nursing budget and some of the things we want to accomplish. We received funding from the Prime Grant, as we talked about earlier, one of the sources of supplemental payments. And we kind of, I don't know the best way to describe it, but I think we kind of had these objectives for the Prime Grant, and we kind of piecemealed them off and all. And for this budget, we've really created a good, clean structure. We have a department called Care Coordination. We have a couple RNs in there. We had an administrative person in there. That position went unfilled for a while. We put that back into the budget. But Care Coordination now will be responsible for quality assurance, will be responsible for case management, will be responsible for administering these grants. I think that one of the things that we talk about is we talk about doing these things so that we can provide this quality of care. We're also have put into the budget some time for a nurse educator. We want to work with the skills of our nurses. One of the challenges we have is that we have the med-surg acute area, we have the ER area, and we need to have our nurses be able to go into both areas with comfort and confidence of what they can do. They don't necessarily have to be there alone, but they need to be that second hand when we get it. We do a thing where we do a mid-shifter we used to do during the summer, which means we just add this additional shift that we add for increases in patient load during the summer. And we almost always have to do this through a registry. So we're going to try and do this through our own personnel, but give them the ability to be able to do this in the ER and see how that goes.
So the care coordination and all of that, is that in the QM?
Yeah.
Okay. So I was gonna ask about that later, but I figured.
Yeah, it's QM and in service of the two areas. One thing we also did is that previously we were trying to run our own, CNA program. And we did it great. Casey Broussard and Ashley and Tiffany Bofferoff, those guys did a great job, help from Pam Valencia, put it together, put on the programs, but we had a horrible time of getting any retention out of it. And it was a great commitment of time to do that, to not get the return. We were successful in it. We've never stopped doing it because the CNAs are a hard get for us. So we're going to discontinue that. And
did we ever try providing any sort of incentive
oh yeah,
along with that? They just.
oh yeah.
Want to stay.
Yeah, maybe they graduate, maybe they go somewhere else, maybe they graduate, we have them graduate the program and then not be able to pass the test. Things like that, or they get through it and they go work somewhere else for whatever reason, personal, professional, who knows what it is. So we were just very unsuccessful with that. Now we know, we've heard that Portola is very successful. We think they're pulling from Reno.
Pulling from Reno.
They're pulling people from Reno, CNAs to come up to go through the program. And, because they had a class and they retained like 6 or something like that, but they need it because they've got multiple nursing homes and they've got 10 beds that they need to take care of, so good for them.
I can remember when the board voted to give pay raises to the CNAs and just to try to retain them here. In spite of that, they still had to leave.
And we've done that. We feel that we pay the CNAs very well. They have a very difficult job. No argument there, but I think we feel that their compensation in comparison to the market is good. So, and then we are also going to have I guess if you will, a true nurse house supervisor. So a house supervisor that's going to work the floor is going to work different shifts and things like that. So the combination of the house supervisor, the nurse educator, I think is going to be where we
Hopefully our staff up.
move the mountain as far as providing that care and being able to do things. One of the things I haven't talked about is that our inpatient and our swing census was incredibly low, and that's understandable. We were not going to accept swing patients during COVID. We just said, no, we're not going to do that, or we're going to be incredibly selective because a lot of the referrals, again, that we were receiving were for post-COVID patients and just couldn't do it. Not that we don't want to help, but we saw how scary it was when we had an incident here. So we're going to go back and look at that. And one of the things is that, and Sean's talked about this, I think at the board meeting, is looking at when we do this, the nurse education and the training, is we look at the skills, does it lend us to, we can handle a different type of patient. We can be able to retain more patients instead of sending them out, transferring them out, and thus increase our census. The other thing we're looking at doing now is that we're migrating towards, and we may be very, very close, if not there, to all of our emergency room physicians are going to have admitting privileges. And so, whether it's a hospitalist program by committee or hospitalist, someone takes the lead on it, that'll be more that we will be able to take admissions, person who admits that patient, follows that patient while they're here, and then there's a better handoff because they're handing them off to the next person that comes in. It doesn't have to always be Dr. Walls or Dr. Ware or Dr. Cooper. The emergency room physicians can work amongst themselves. And thus we could potentially increase both the inpatient and the swing bed utilization. And that's, Sean talks about capacity, that we're staffing our inpatient budget, swing budget is around 1. We're staffing not because we anticipate it, but we have to, for 3 to 4. So we have this excess capacity. I know it'd be a lot. I mean, it'd be a busy little hospital, but where we could potentially have a census of 3 or so, and that's all more or less incremental revenue other than the supplies that the patient consumes. And so there's this opportunity to do that, provided that we have the things in place, whether it be the nursing skill sets or the hospitalist type thing. So there's an opportunity there. Okay, so the Lake Almanor Clinic, back to the FTEs on the bottom of page 12. And we'll see it also in the contract, or the pro fees. Historically, all of our providers, whether it be a physician or a allied health professional, nurse practitioner, PA, has always been contract. Well, mostly way back we had employee, but recently anyway. And so Sonia is an employee. so it's an employee there and a minus from other pro fees. And then our contract nursing. Now this will go down when we're able to, our contract FTEs, we have a phlebotomist, a contract phlebotomist in the lab that'll end in August. And we're anticipating maybe having to bring in a contract radiology tech when our current guy leaves. I don't know the timing on all that, but we're looking for employee tech and employee manager as well. But we may have to fill that if the per diem person we have right now has to leave. Other expenses, just kind of talk about the contract labor that we're going to have the lab and radiology for some period of time. The decrease in professional fees, medical, again, it's the Sonia employee versus independent contractor. I didn't want to talk about voluntary, but we've incurred some legal fees during this past year that we do not anticipate a replication of. It's not going to be a nice place around here. So we anticipate that going down, and then the decrease in the supplies because of the COVID-related testing expenses, supply expenses. So bottom line, net income loss. Boy, I jumped right to the bottom line, didn't I? Okay, I put everything in. This is a busy slide. Bottom of page 13, net income loss with IGT. So I went through all the components. That there's a $1.1 million decrease over what we're estimating for this year. We do have a $2 million decrease in the net operating loss, but right now we're projecting a $815,000 decrease in non-operating revenue, and this is really just at this point not budgeting to recognize any provider relief fund. But I think we've talked ourselves into it a little bit here today that we're going to be bringing some money in, and probably a pretty substantial chunk of money. However, the only caveat there is it may come into 2021 versus 22. So, but there's no additional, in our projection for 21, there's no additional money. So either way, and the significance of this is that this income, if we do it, is paper income. The only thing that happens is we take whatever amount of income we recognize and we take that similar amount of cash and move it from a designated or restricted classification into unrestricted. So like I said, we've got the money sitting there. If we recognize income, it's a paper income, but what we then have is a like amount of cash that's unrestricted and available for whatever we want to do. So the fourth bullet here is really the one that is both impacting us and something that we just need to be aware of. So for fiscal 21-22, our net income, net of IGT, is decreasing $2.3 million in the supplemental payment program due to changes in the program structures. For fiscal 21-22, the prime grant is transitioning to what's called QIP, or Quality Improvement Program, and there will be no payments made during fiscal 21-22. Payments will start in fiscal 22-23, but we probably won't see it until the very first part of calendar 2023.
Do we think they're gonna do 2 years worth of payments in the first year, or just a year?
They said they kind of made it up to us with this year, and they kind of have. So,
So it'll probably just be 1 year's worth.
double check on
Is
that.
it, do you think, we anticipate it'll be a similar amount?
Well, what they did is they built in a deal for hospitals like us. The new program is going to go to what they call claims-based. This and all of the other supplemental programs. It's where it's going to be based upon your actual Medi-Cal volume. And that's going to determine your payment. But for the Prime grant, what they've done is they built in a floor of a net benefit of $750,000. And that's us. So we can expect $750,000 net a year. As long as the program goes, yeah. I'll double check on that Prime for a minute. What they'll pay in 2023 and so for fiscal 21, since we received those additional Prime grant payments, the impact to us is $1 million. The net impact is $1 million. So the rate range and hospital quality assurance fee program are going to a calendar year as opposed to a state fiscal year, July to June. And so for 21-22, we're only going to receive a half-year payment. But that half year will be through December of 2020. So they're still going to be a year behind.
Any reason why they're shifting to a calendar year?
I've never heard a good one.
It seems odd.
So the impact of that is compared to 2021 is 1.3 million. So we're losing all of Prime and half a year of the rate range HQAF, and it's costing us $2.3 million. So that, I don't know if you want to classify it as a wake-up call or life without picture, whatever it is. It just shows how fragile we are and how dependent we are on that additional money and how critical it is to bring that operating loss down to a more manageable number. Right? Okay, so that was the bottom of page 13. So now kind of the good news, if there is any here. So this top of page 14, this is what we're projecting to be our cash position at the end of this month. We're projecting that we'll have total cash on hand of $15,600,000. Now, of that $15,600,000, we talk about designated or restricted or whatever. We have a designated capital reserve, and I'll show you there's an analysis in here of how I got to that number. It's a combination of what you guys approved for 2020, fiscal year 19-20 that we ended up never fully spending, and then the add-on you guys just did for all this wonderful stuff that's going on outside. More to follow. Then we have the provider relief fund deferred amount of $3.5 million. We have this designated operating reserve, which is, you guys established a contingency fund, and we've just been adding the interest income we get from the LAIF account to that. It comes in quarterly. So it's now up to $722,600. The PPP loan of $1.5 million. So that adds up to just a little over $7 million in designated or restricted funds. What it leaves us with is $8.6 million of unrestricted cash or 175 days cash on hand, which is.
When I got to this slide, I started feeling a little bit better.
Yeah. Well, it's like I always, I present those financial statements and monthly to you guys, and I just say, our balance sheet's strong, our cash position is good, and it's all true. But as we found out, those of you guys that have been on the strategic planning, there's a big bill coming that we're gonna need.
This is the inheritance. you know, as the intergovernment transfers and all these things start to shake loose and the timing changes on them, this is all the more reason to get to that net zero operating. Right, so that is truly money that goes into our cash flow, it's available to us to use for different types of things. So it's a real focus to increase our volume and maintain or decrease our expenses. Got to get close to zero.
Okay, so the second slide on page 14 is what I'm projecting our cash position to be with this budget that we've put forth. So the total in cash on hand will go down to $14 million, just over $14 million. One of the things is that we are projecting that we'll spend the entire capital reserve, $1,277,000. Still no movement on the deferred revenue, the designated operating reserves. I added interest income, current budget, and interest income to it. PPP loan still there. So to leave us with unrestricted cash, $8.183 million or 167 unrestricted days of cash on hand. Okay. I think that's the operating piece. I did some capital budget information, not asking you to approve a capital budget at this point. Do we want to talk about the operating budget, or do you just want me to finish up with these last couple of slides?
And Kristen?
I think we can probably move to a quick.
Okay, yep. Okay, so the capital budget, if you will. So again, bottom of page 15, slide 30. So the total board approved amount, I've got a $1,277,000. And of this, 570 is amount unspent from the amount that the board approved in 1920. And if you're curious, there was 400,000 set aside for the emergency department EHR, whether it be T systems or whatever. And then we were looking at doing the GERD program with Dr. Jensen. And then there was some money for continued acquisition of hospital beds. So that added to 570. The rest of this is the stuff that you guys, some of it that you approved. We had 250,000 in the 1920 budget for the hospital. You guys gave us another 50,000, so it's now at 300. The painting for 70, the flooring for 150. Work on the new hospital site, again, 85,000 of that was from the 1920 budget. 40,000 is for all the geo stuff that's going, the survey stuff that's going on, and then some other campus project, the signage and all that. So that's 62,000. So all those together add up to 1,277,000. The last slide, which is the top of the last page. So we're looking at a couple other things and got the rug pulled out from under us because we thought we were going to have till the end of December to spend all our COVID money, but now we obviously have been given a different direction. So we were looking to, when the box car gets out of there, the rail car gets out of there, we're looking to put some kind of structure there for storage to comply with the CDPH mandates regarding days of PPE on hand. And so we were planning to use the provider relief funds. There may still be some provider relief funds out there that we can apply for now that we know that the timing of things, but we'll just have to look at that kind of.
Is it possible to cut a check before the end of the day and deliver it?
Possibly.
Possibly.
We're gonna have to skedaddle.
What about approval at 2? The negative pressure room.
Well, the negative pressure room, the good news is that the state just came out and said they have SHIP, which is Small Hospital Improvement Program, grant funds up to $230,000
For this purpose?
for COVID,
Improvement, yeah.
Okay.
for generic COVID things, so we can apply for that. There's also a employment, payroll tax credit program out there that we can possibly apply to. So we're gonna look at that. That one we were gonna not do because we thought we'd just spend our time and give it back. So those are the two things that we're looking at that we thought we had targeted funds for, and maybe we still do. Then the last two bullets, in the next fiscal year, we're gonna have some costs associated with the development and planning of the new facility. We're working on a budget for that. What those numbers will be kind of changing because we thought we were gonna be moving forward with the schematic design. We may not, what form that is, but that'd be something we'd have to bring back to the board to ask for. The last thing is looking at the implementation of a new electronic health record and information system. What we have from Cerner right now in their proposal, we did not budget for adopting the electronic health record in the current fiscal or the budgeted fiscal year. I don't even know what the timing of that would be. They say it's going to take 9 months. We don't pay for it until it's live. So there would only be a couple months if they got going soon, which I don't know about that. But they did give us a hard cost that we pay for their out of pockets for the implementation of the system. And they gave us a quote of that. So that's just a number that's bouncing around out there. We're not asking for those funds. And quite frankly, at this time, we're not asking for any capital dollars because we've been able to get pretty much everything we wanted because of COVID.
And then as far as the new information system, would that proposal be for campus-wide?
Yes. Including skilled nursing.
Including the ER,
Yes.
so we wouldn't have to spend 400,000 on.
No, T systems will go away. Their ER system it does a lot of the same things T systems does.
Okay, so just quickly, and then I'll take questions or whatever everyone's pleasure is. So in addition to this presentation that we just went through, there's another document in your materials that went out. And it's entitled FY 21-22 operating budget. This is just the actual budget with a comparison to actual 2020, projected 2021, and then the detail of these numbers or summary detail of these numbers that were in the presentation, and some supporting analysis both from the revenue and expense side. The other document I provided to you was a cash flow document, and that's where we get to both our cash position for 2021 and then for the budget. So just more information.
It all looks great. The only question that I had, we already answered, and that had to do with the quality measure.
Thank you.
All right, so
Excellent. Steve, I just want to say great work. And I mean, we've been running on months and months.
I have been, and I'll tell you what you don't see here, board members, is these are just numbers. There was a lot of humanistic part to this budget process where we started looking at changing some of the way we do things, the way we approach things, and the investment that we're going to make in people, but at the same time, the return we want on that investment. And so it was a interesting experience, both necessary and very, very positive.
Steve, I always appreciate your presentations. We get the printouts and take a look at those, but when we hear you talk, you add so much texture to it, makes it much more understandable. So I very much appreciate it. Warts and all, I like it.
Warts and all. Okay, and so I guess I'll just look forward to
Next board meeting, we should approve.
Well, no, I don't know if
He is, he's
Okay,
online.
Okay, never mind.
Okay,
Gary,
Dan?
I'm having a little difficulty hearing you. But I was just going to say, as I stated earlier in the meeting, that I think it would be more appropriate for us to take a look at the materials that have been prepared for us now that we've had Steve's input and some additional insight, and then to schedule our vote on this at the next meeting.
Ken, I'm in the same room with her and I have a hard time hearing her, so don't worry.
Sorry, Dr. Walls.
So we want to schedule then get on the agenda to vote.
Sean, Sean,
Here,
what is your,
here. So, thank you.
can I get on here?
Yeah, you're here.
Okay, Sean, what's your plan, cutting over to Cerner? Do you have a timeline?
Well, there's still some things that the revenue cycle piece needs to move through. Steve, so we vetted it clinically and it met with overall approval. There's some stuff on the revenue cycle side that Steve is working with Cerner to vet. I mean, it's great that we have a great clinical system, but it also has to feed into our billing capabilities and our ability to generate financial reporting. So we still have some things that Steve's working through over the next, week, Steve? Week and a half?
My next meetings with them is next Monday.
So once we get the green light from Steve that the financial element of the single platform is going to fit for our reporting and our ability to do billing, then I think we're going to get into a discussion. I'm already reviewing, and so is legal, going to be reviewing the contract. I have it in my inbox. We have to be very, 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 very specific about some things in there, and there's some ambiguity. So I'm already reviewing the contract while Steve takes a look at the revenue cycle side, and if everything is copacetic, we are, very possibly going to be coming to the board for approval to move our electronic health record to Cerner. And that will also incorporate the approval of the $143,000 that's necessary for the project. From start to finish, if we depend upon when we kick it off, Cerner is saying depend upon resources, we're looking at a 9-month transition, 9 months. So we'll probably know by the July board meeting.
Will it generate a bill when the patient leaves the office?
It generates the bill off of the coding, yes.
Yeah,
Yes.
but I mean, when they leave the examination on the way out, is their bill complete then?
It's completed against clinical documentation. We're still dependent on clinical documentation to drop the bill.
Right.
Completion, but the clinical documentation element of this kind of leading to what you were talking about is much simpler. It's just a much simpler program to drop that. So collection of copays will start happening on sale.
Are our physicians involved in making the decision to make the cutover?
I'm sorry, I missed that, Rich.
The question that Dr. Walls asked concerns me. Has our medical staff looked at the Cerner product?
Yes, we did a complete demo. And we can, all the demos are also recorded. They can take a look. Dr. Jensen's actually offered up some of his assistance in answering questions for medical staff as he uses the PDH all the time.
Okay.
So yes, everybody was exposed to it. They had the opportunity to be exposed to it. We're giving them opportunity, more opportunity.
Okay.
Other questions, folks? I am thinking then we're probably at the end of our agenda for this meeting, and our next meeting is June 24th, 3 p.m. And Sean, you'll keep us advised about the new developments about COVID restrictions. I understand a lot of things that are supposed to change tomorrow.
Yes, supposed to change tomorrow. Kind of. I'm working with Stephanie because Stephanie's all over it. So we are going to adhere and be very conservative in our approach to our COVID changes. Just
Probably have different restrictions for
hospital
medical providers, yeah.
Hospitals definitely have different restrictions. It's masking no matter what, whether you're vaccinated or not. a setting like this is not considered hospital. But I am gonna look to my nurse, my chief nurse on infectious disease and infection control to set a precedent, set the tone.
Okay.
Yep.
Okay, folks, anything else? If not, we'll just carry the budget over to next meeting.
Thank you.
Thank you.
Thank you all. Meeting adjourned.